In this unit, we will talk about medical therapy, that is the first choice for symptomatic endometriosis in adolescent population. According to the most recent guidelines released in 2022 by European Society of Human Reproduction and Embryology, in adolescents with severe dysmenorrhea and/or endometriosis-associated pain, clinicians should prescribe hormonal contraceptives or progestogens as first-line treatment because they are effective and safe. Patient counseling is the first step. Before prescribing medical therapy, clinicians should take into account and discuss with the patient, first of all, the efficacy on pain reduction. Then they have to discuss the safety of treatments. Primarily, we have to consider that peak bone mass is reached in late adolescence and related to estrogen levels, which are reduced by hormonal treatments. Other aspects to discuss are tolerability and side effects, as well as contraindications to treatments. Routes of administration and regimens of different therapeutic options should also be discussed. The young patient should be involved and adequately counseled in the choice of the therapy, considering also her individual preference and needs, such as the need of contraception or the need of period control, in the view of a tailored treatment. Among different therapeutic options, combined oral contraceptives and progestogens are the first-line medical treatments of symptomatic endometriosis in adolescents, because they have shown efficacy in the reduction of pain, as well as good safety and tolerability profile, which allow a long-term use. Combined oral contraceptives are estrogen-progestogens compounds. They are effective in reducing endometriosis-associated pain with the advantages of contraception and periods control. No difference between different formulations of combined oral contraceptives are reported in terms of endometriosis pain control, but for safety reasons related to bone health, it's better to prefer combinations with doses of ethinyl estradiol greater than 30 micrograms instead of lower dose preparations. Various routes of administration are available. The oral route, the transdermal route, we have a patch, and the vaginal route, we have a vaginal ring. Different regimens may be used. We have the cyclic regimen and the continuous regimen. In the cyclic regimen, we can have an hormone-free interval. We have the classic 21 and 7, or the extended regimens with 24 and 4, or 26 and 2. While in the continuous regimen, we have no hormone-free interval. In case of pain symptoms during the hormone-free interval, in those patients assuming a cyclic regimens, it's better to prefer the continuous regimen. Progestogens are effective in reducing endometriosis-associated pain. Various routes of administration are available. The oral, the intrauterine, we have the coil, and the subcutaneous, we have an implant with etonogestrel. Among oral formulations, we have norethistron acetate 2.5 mg per day and Dianogest 2 mg per day. They are both approved for endometriosis treatment, but have no contraceptive effect. An oral progestogen with contraceptive effect is desogestrel 75 microgram per day. Among progestogens, long-active reversible contraceptives are used in endometriosis treatment and are the levonorgestrel intrauterine system and the subcutaneous etonogestrel implant. No difference between different formulations of progestogens are reported in terms of endometriosis pain control, but long-active reversible contraceptives do not appear to affect peak bone mass acquisition or future fracture risk. Therefore, they are a good therapeutic option in adolescents who also need long-term contraception. As regards levonorgestrel intrauterine system, from 2015 smaller intrauterine systems are available and they can be used in adolescents. They are effective in reducing dysmenorrhea and have the advantage of reducing heavy menstrual bleeding. They are therefore useful in adolescents with symptomatic adenomyosis who suffer from dysmenorrhea and heavy menstrual bleeding. Women who suffer from dysmenorrhea, and in particular adolescents, more frequently experience pain during the insertion of the intrauterine device, and also in the first months afterwards. So, before the insertion, counseling the patient is very important for the compliance, and after the insertion, analgesics may be prescribed. Among oral progestogens, a multi-center prospective study was conducted in 97 adolescents treated with Dienoges 2 mg per day for 12 months. The effect on pain scores, quality of life, and lumbar spine bone mineral density was investigated. After 12 months of treatment, pain was reduced and quality of life improved, but bone mineral density decreased, with partial recovery 6 months after treatment discontinuation. A practical advice may be to prescribe Dienoges for 6-12 months and then switch to an estrogen-progestogen compound with an adequate dose of estrogen. As second-line medical treatments, gonadotropin-releasing hormone agonists may be considered, but should be associated with a combined hormonal head-back therapy for safety reasons, mainly related to bone health. Therefore, they should be used only after careful consideration if first-line treatments failed. Another disadvantage is that they may be not used for long-term periods, but just for up to 1 year with head-back therapy, and in case of symptom persistence, surgery should be considered. Among medical treatments, non-steroidal anti-inflammatory drugs may be also used for the analgesic and anti-inflammatory effects. Side effects, mainly related to gastrointestinal system, should be discussed with the patient. As take-home messages, we can say that medical therapy is the first choice for symptomatic endometriosis in adolescent population. Combined oral contraceptives or progestogens are the first-line treatments. GnRH agonists can be used only after careful consideration with head-back therapy for up to 1 year as second-line treatments, only if first-line treatments failed. The woman should be involved and adequately counseled in the choice of the therapy, considering also her individual preference and needs in the view of a tailored treatment. Follow-up is crucial in order to verify the efficacy of the therapy prescribed and variation of the woman's needs.